All right, guys, we'll get going. Thanks for y'all that showed up in person. Welcome to EMS Challenge. I'd like to say Happy Veterans Day. Thanks for the service. I know there's a lot of folks that are military, retired, or veterans, and I appreciate your service. We did decide to go ahead and do a class today for the folks that are on duty. So thanks for logging in, and be safe out there. It's horrible weather. Nice, cold, and wet out there. All right, so EMS Challenge, for those that have not been here before, we started a couple of years ago to improve Con Ed in the region, kind of give you access to physicians that work in the region as well. You can kind of read what challenge stands for. But the goal of all this is to increase knowledge base for EMS and overall patient care to take care of the folks that we need to. For your Con Ed certificate today, you can look at the chat box. There'll be a link there that Chief Ward will put out for you. You can also email us at alabamaemschallenge@gmail.com. Try to get those into us this afternoon, and we'll get these certificates back out to you. Regional updates, don't forget, protocols did change recently back in June. There are a lot of things out there, especially at the EMT level. There's blind insertion devices. If you guys are going to use those, whether it be a King or an iGel, make sure that you train with that. Make sure your med director's on board with those as well, because that is new stuff for EMTs that was not taught in basic training until just now. Remember, we have our YouTube channel, Alabama EMS Challenge is up and running. You can actually watch those videos. There's a quiz at the end of them, and then a link that will let you get Con Ed certificates for that. Continuing education, National Registry has waived the in-person training for this cycle. So if you need Con Ed, you can use the YouTube channel for EMS Challenge. COVID is still here. Numbers in the greater Birmingham area are about the same. I know the media is talking about a slight rise in that. That might be the case, but the short version is COVID is still here, so be safe. Wear your PPE. Flu season will be starting soon as well, so be safe with that stuff, guys. Wall times or parking, whatever you want to call it, a big issue. They've been a big issue nationally for a long time. Things kind of eased up for the region when we had the lockdown and numbers went down, but wall times are back up again. We have talked in the past about how to manage this. Obviously, there's no reason to be standing on a wall waiting for a bed at a hospital for hours. That needs to be taken care of. But you also have to be nice and be reasonable. Remember, when you arrive at an ER with a patient, it takes them a few minutes to find a room, even if they have one open. They need a few minutes to get transition of care over and do that. So don't cut them short. Don't be disgruntled and expect this to be done in 5 or 10 minutes. However, if the time gets really extended, those do need to be addressed as well. Remember, the goal of all this is take care of people. And I understand that with the long wall times, communities are not having the resources they need. They're not rescue units, ambulances out. They can manage that. So the hospital has an obligation to get you back out in the field. But we also have an obligation to do a timely, reasonable, and adequate transfer of care. So be nice. Let's all work together. I know a lot of places that are having time limits, and that's reasonable as long as there's nothing crazy going on. Remember, just as EMS is being stretched to the limits, so are some of the ERs. And if you arrive at an ER and they're running a code with someone and the resources are taken away, give them a few extra minutes to take care of your patient as well. So work as a team. System entry, remember early entry at TCC for stroke, trauma, or STEMIs. When you get on scene, you recognize the patient meets one of the criteria, call ahead, give us a few minutes so we can get you routed to the right hospital. We've talked about medical direction in the past with all the new changes, the new drugs coming out at ALS, and even the BLS requirements. If you do not have an active medical director that's a practicing ER physician, you need one. The time is now. If you want help, reach out to us in this region. We'll find somebody. If you don't like me, you want to offend me, we'll get somebody that works in one of the hospitals in this area and we'll help you out with that. But you need an active medical director. Ketamine, I'll talk about in a second. I always talk about ketamine. We'll talk about dosage again next time. A couple other things I wanted to mention that was announced at our state conference was Jamie Gray is now the interim director, state director for EMS. Jamie Gray is at state office. The other thing I wanted to mention is vanity in a way. We now have Alabama EMS Challenge t-shirts. If you show up in person, we're giving some of these out. So think about that in the future. We are practicing social distancing and being safe with COVID as well. Educational opportunities coming up. will be November 18th. We're being sponsored by the Fire College, one day a month now. We'll be at Shelby Baptist Hospital with Alabaster Fire being the sponsoring agency. We'll do 9 to 11 lectures. It'll be myself and then Dr. Rose from UAB. And then from 1 to 3 at Shelby Baptist, we'll do skills labs. We'll do airway management. We can do some pit crew CPR and then some scenario-based training. Dr. Duerring may be there as well. But don't miss that. That's in the Brims region. It's local. Easy Con Ed, good hands-on skills, and you have at least 3 physicians there to help you out. Don't miss it. December 9th will be in Anniston doing the same thing, lectures 9 to 11. And then from 1 to 3 doing skill stations, airway management, CPR, or pit crew CPR, some scenarios, and I may even be doing some surgical airways there. I got a few extra pig trachs. January 28th, we'll be at Foley, same things, lectures 9 to 11, and then 1 to 3 doing skills. Don't miss it out. It's a great opportunity, guys. All right, and again, this is being sponsored by the Fire College. There's no cost to show up for this. So ketamine, Region's doing great with that. I don't see a lot of issues with that now, so thank you so much for keeping up with this. Just remember, when you give someone ketamine, whether it be for pain or excited delirium, once someone gets ketamine, they're now a critical patient. You expose them, you cut their clothes off, you look at them, you look for life threats or their patches, their holes, anything that can be dangerous to them. They get on the cardiac monitor. They get at least get a SAT monitor. If they get hypoxic, we do not apply oxygen. We open the airway, jaw thrust, nasal trumpet. If that fixes them, we high five each other and smile. If that doesn't fix them, then we assist ventilations with oxygen, okay? Inside of capnography is also useful if you're able to do that. In the unintubated patient, do that as well. But remember, post-ketamine hypoxia does not get oxygen until they get airway management, all right? All right, so let's talk about some 12 leads today. The goal for EMS Challenge, we'll do STEMI 12 leads once a month, maybe every other month for a while. Folks are doing really good with this. I got a few cases we'll talk about. But when I think about 12 leads, these are a screening tool. And we're thinking, is the ventricular rate too fast, too slow, or okay-ish? With the too fast, American Heart does a great job with that, in my opinion. Too slow, things I think about as drugs or electrolytes or ischemia. Anything else that causes bradycardia, you should pick up in your primary exam when you're looking over your patient. The scarier EKGs are the ones that are kind of okay-ish in the rate, but is it a STEMI? Is it not a STEMI? Is it hyperkalemia? What's going on? We've got some good saves this month we can talk about. You gotta know how to calculate your rate. Don't just trust the monitor. When you print that 3 lead or 12 lead off, I use the box method, but you gotta make sure the machine is correct. Sometimes the machine is not correct. Have a way to calculate your rate. Intervals, you got to know PR interval, you got to do QRS, very important, determines a bundle branch block. Also with the QRS, you can determine hyperkalemia. PR interval, very important, especially when you think about determining between AFib and a sinus rhythm, or again, hyperkalemia. QT interval, very important. If someone's got a long QT, there's certain medicines we cannot give them in the field. And also someone with a long QT who has passed out or had syncope or a seizure-like activity, you got to be very concerned about them having a dysrhythmia, and those folks should go to the hospital and not just be kind of PRT. So, quick review. Too fast, too slow are okay. I said the ventricular rate's okay. I use 50 to 140-ish is my number, but box method would say that this would be 300, 150, 100, 70-ish. Relative rate, so 70 is fine. So that rate is okay. So the next thing I'm gonna look at this is injury patterns. And we've talked about this a lot as well, but this is repetition, good way to learn. So lateral injury pattern. So I'm looking at V1, lead 1, AVL, and 5 and 6. These are my lateral leads. I'm looking for ST elevation. All right, obviously any 2 leads with elevation, that would be a STEMI. I'm also looking for depression or T-wave inversion, concerning for ischemia, things that make you uncomfortable. Next thing I look is 2, 3, and AVF. These are inferior leads. Again, for elevation or ST depression. 2 leads with ST elevation, 1 millimeter or more is a STEMI equivalent. That should, or a STEMI, and they should be put into the system and managed appropriately. The last place I look is, not last place, but is V1 through V4. And again, these are your anterior leads here. And these are your septal leads. Kind of runs down the middle of the heart. So ST elevation there is concerning for a septal or anterior MI. You can also have ST depression. This is years ago when we used to look at the 12 lead, we'll look at the paper EKG, we'll flip it over on the backside and look for elevation, looking for a posterior infarct. But ST depression in V2, V3, or V4. Oh, that was kind of strange. Is definitely concerning for posterior infarct. All right, so posterior STEMI, a lot of academics, textbooks talk about you can take your leads off the front, put them on the backside, do a posterior EKG. No need to do that in the field or the ER. That's kind of academic-ish. If we have time or we're waiting for the cardiologist or the cath lab, yes. Otherwise, don't waste your time. This is enough to say it is a STEMI. Put them in the system, do the appropriate care, get them to the cath lab. And then the last place we look at lead AVR, and this came out about 7 years ago, and it's just now catching on really well in our area. So thanks for what you do, guys. I'm seeing a lot of good saves with this. We used to say that AVR was only good for lead placement. If you're up in one, you should be down in AVR, and that's true. But AVR has some other uses. Elevation of lead AVR with the where else in an injury pattern, be it inferior or lateral, all right, is concerning for a left main occlusion, and it's called a STEMI equivalent. Should be entered into the system, should be treated accordingly, should be seen by a cardiologist. Now, obviously, some of these folks with AVR elevation, it could be the 80-year-old that is now septic with a heart rate of 100, and they have known heart disease, and they're just got a strain pattern, and AVR goes up. And when I fix their heart rate and their blood pressure for them sepsis, that elevation goes away. But think about the patient, get a good history and physical, but AVR elevation, depression anywhere else in the right setting, the STEMI equivalent. And this is just a diagram I swiped off Google that kind of shows the anatomy of this. So elevation in AVR is concerning for something really close to the cusp of the aorta, where the left and right coronary arteries come off. The LAD, the main part of the heart, to circumflex, usually off the left side of the heart, but sometimes off the right, and then inferior. And yes, I am beating a horse to death, or can't beat a dead horse. What's that phrase? Something about a dead horse? Oh, okay. Oh, that's what it was. I messed that up. Okay. All right. Sorry. Well, I messed that up. But either way, the point is repetition. You're not going to get good at 12 leads. You're not going to recognize STEMIs, recognize injury patterns unless you look at a lot of these. I'm on the monitor. I'm counting respiratory rate. In my mind, I'm thinking 15 seconds, and I start counting. If they get over 6 breaths in those first 15 seconds, that's too much. I'm done counting. I don't really care. A respiratory rate of 24 versus 34 doesn't really matter. It's all too fast in the adult population. So you look at work of breathing, accessory muscle use, are they wheezing, are they striders, are they head bobbing, what do they look like, okay? So don't get tied up in those numbers. In the ER, you can look at triage notes from a day, and you'll see that most folks have a respiratory rate of 12, unless they complain of shortness of breath, then it's 16, or they're dead, then it's 0, right? So it's just a rough estimate. I know you're not supposed to say that, but that's what it is. They're set 96%, that's reasonable. Blood pressure, that's normal, which is way too low for Alabama, but we'll call it good. And always get a D-stick, gives you a lot of data. Remember, glucose that reads low, we can fix it. If it reads high, we know what the problem is. They're either in DKA or hyperosmolar. We expect problems with that. Anything in between doesn't give you a lot of data. You can still use it, but D-stick gives you a lot of information, all right? EMS, we don't have a lot of labs, but we do have D-sticks, and now we have capnography. That'll give you a lot of information, folks, a lot of information. So this is the 12 lead. Too fast, too slow, or okay. I say it looks a bit too fast. Machine says it's 200. I'm gonna look at this and I'm gonna double check that. So I'm gonna say first box is 300, then I'm 150. So between 150 and 300. So yeah, I agree with that. All right. So a little bit fast. All right. I'm gonna say, is it regular or irregular? What do y'all think? Anybody in the room care to take the bait? Yeah. So I don't know. I know the answer. I say it looks pretty regular to me. It's pretty tough. You can get out a sheet of paper, take that paper and kind of mark the QRS axis and march out to see if it's regular. Okay, maybe a little irregular there. But the way you really want to determine irregularity or regularity is put your hand on the patient's pulse. All right, reach down, grab the wrist, feel the carotid, throw your stethoscope, get it out of the jump bag, put it on the chest, listen to the heart, and listen for irregularity. When you get rates greater than 160 or 180 on these machines, it all looks pretty regular at first glance, and you can kind of mess up your diagnosis, all right? So feel the pulse, check for regularity. Other thing I'm thinking about is a QRS wide or narrow? And I would say it's narrow, all right? It's less than one small box. They give it a QRS of 72, less than 120. So I have a narrow complex QRS, all right, that looks fairly regular, all right, until I put my hand on the pulse. And then I recognize that it's pretty irregular. So AFib with rapid ventricular response can do this. Now, obviously, sometimes you see AFib with RVR that has a rate that looks like this. Then you look up and the rate's 160, 140, 190, 210. With that kind of variability on the monitor, it gives you a pretty good clue that's probably AFib, RVR, rapid ventricular response. But the best way to figure this out is hand on the pulse. Gives you a lot of data, right? So what is AFib? AFib is probably the most common dysrhythmia you're going to see in your career. It's basically where the top part of the heart gets stretched out and becomes has kind of chaotic movements. Most common causes are COPD, anything that causes right-sided heart strain. Okay, it causes two problems. First problem is decreased cardiac output. So you lose that conciseness or the ability of the heart to function and work well together, the atrial and the ventricles, because the atrial is not contracting with the ventricles anymore. The other problem is you get thrombus formation. So folks with AFib have higher risk for throwing clots, whether it be a stroke or a PE, or having a DVT as well. So AFib, pretty common, all right? The problem with this is the fact that that rate was so high. When you think about normal conduction is the SA node, fires across both atria, everything meets back in the AV node, and the ventricles fire. Everything works great. With AFib, what usually has happened is you got a diseased heart, either from ischemia or from right heart strain. So if there's pressure, increased pressure in the lungs, right? It backflows the fluid, this heart stretches out, and then instead of having the SA node being the leader in electrical contraction, it's all over. So the way I kind of think of this is that the atrial or the heart itself is kind of a wire mesh, right? And electricity starts in the SA node. As you stretch this, it kind of messes up those wires. But the cool thing is that all heart muscle can conduct electricity and start an impulse. And that's kind of a safety valve, right? But it's a bad thing when this stretches out, then you get different parts of the atria firing. So the atria does not contract completely. It's not in synchrony with the ventricles. So AFib. Now again, it's a pretty common dysrhythmia. Causes long-term hypertension. You get left-sided issues with hypertension here, increased pressures, which increases pressures in the lungs, and it causes this to stretch out, both the right and left atria. Hyperthyroid, we'll talk about in a couple of weeks. We'll talk about some endocrine emergencies. Alcohol will actually jack up the heart and make you get into AFib even as a young person. So chronic alcohol use is a problem, or the binge drinker, you'll see that, okay? Obviously something that's symptomatic, so the guy smoking some crack, doing some meth or some spice can get AFib. COPD we kind of talked about. Other things acutely that can cause it is a PE. So you got a 40-year-old guy, no history of atrial fibrillation, doesn't smoke, now comes in dyspneic, hypoxic, and AFib. He's got acute right-sided heart strain. You think PE on that guy until proven otherwise. Electrolytes, remember all the electrical activity in the heart is based upon chemicals, electrolytes. So if those are jacked up, you can get AFib. And obviously heart failure, cardiomyopathy. What that does with congestive heart failure or cardiomyopathy, the heart gets larger, and as the heart gets bigger, again, it goes back to my redneck interpretation. It kind of stretches the ventricles and the atria, which jacks up the conduction system, and makes you more prone to have AFib. People who also have heart failure and their heart function is less than about 20%, they are very prone to going into VFib. And VFib is very bad. So folks with bad heart failure get an internal defibrillator placed on them. So if they go into VFib, they can be shocked out of it and not die. We don't do that with AFib. AFib is usually not a life-threatening rhythm, and as it goes on long, most folks have time to come to the hospital. And same thing with heart disease, valvular disease. It causes the heart itself to get larger, stretches the atrias, makes you more prone to having AFib. We talked about the problems. So folks with AFib, if their body gets stressed, they can go in that RVR, rapid ventricular rate, and that decreases cardiac output. So less blood flow to the brain, they can pass out, okay? They have decreased exercise intolerance because the heart doesn't function well, it's not in synchrony with each other, the top and the bottom, all right? And then obviously they can have clot formation because as the heart quivers, blood stays in there, it gets churned up, gets thick, then when it gets into the ventricle, they can pump it out and get a PE, or if it's left-sided, they can pump it out and that goes up and they can get a stroke. So AFib does have its problems. Acute management of AFib, this is the kicker. How do we manage AFib? So you got to determine, is the rate, this RVR, this fast heart rate, the problem, or is it the response to a problem? So AFib with RVR is the sinus tach, people who just have a regular heart. So if I go out and run 200 meters, my heart rate can go up to like 140, 150 because I'm out of shape and my body needs an increased heart rate to keep up with cardiac output, right? Because cardiac output is heart rate times stroke volume. That's the amount of blood the heart pumps each time. So if I have AFib, because I've smoked for 20 or 30 years, and now I get sick and get septic and I get dehydrated, the body's going to respond by increasing this heart rate. And if you have AFib, increase the heart rate, you get AFib with RVR, right? So if I got a septic patient that's dehydrated and I try to shock them out of this AFib RVR, and I take them from a heart rate of 140 to a heart rate of 60, I'm going to drop their cardiac output, drop their blood pressure, they're going to have problems. So you got to determine with this AFib RVR, is the heart rate the problem or is it the response to the problem? If it's the problem, we got to fix it. If it's a response to something, dehydration, fever, infection, volume depletion from a gunshot wound or a car wreck, then we don't want to correct the rate to correct the underlying problem. That makes sense? Yes, no, nobody care? Nobody care? Oh, thank you. All right. Sweet. So, what now? Oh, okay. Well, good. I'm excited. So, in AFib, for years we talked about time frame makes a big difference. So less than 48 hours or greater than 48 hours. That was the magic number. So we said if you had AFib more than 48 hours, the risk of having a big clot in that atria is pretty high. So with those folks, we did rate control and we made sure they didn't have a clot in the heart before we converted them out of that AFib, if we could, all right? So we'd anticoagulate them, put them on blood thinners for 3 weeks, do an echo, make sure there's no blood clot, and then fix the problem. If it's less than 48 hours, we used to do cardioversion. So we would synchronize cardiovert these people, sedate them, zap them, and knock them out of AFib. What we found out is a couple things. One, most people with AFib RVR, if you synchronize cardiovert them out of that AFib RVR, you fix the problem for now, but there's probably some kind of long-standing problem that caused that AFib. So we didn't fix their hypertension or COPD, so they go back into AFib in a couple of weeks. So what was the point? What they really need to do is treat the underlying problem and then go into the cath lab. And what they do with that is the cardiologist, again, my high-tech heart, right? Runs a wire up like they're going to do a stent for a STEMI. They look, they put the person in AFib and they can kind of see where the impulses are coming from and they burn those places out with cautery with the hopes that the SA node kicks back in and you get out of AFib for long term. All right. Other things that we can do is we can do rate control as well. And that's what we do for the most part these days is rate control, because most folks in AFib RVR, even if we synchronize cardiovert them, is not going to last long term. All right. So we've got to change the way we thought about this. So we can rate control people with beta blockers. Metoprolol is one we use in the ER, or esmolol for those folks that work in the ER. DILT is something we have recently approved in the state, so we can do diltiazem and for pre-hospital use. I got no problem with that. Diltiazem, a calcium channel blocker, works great. It's relatively safe. We used to think calcium channel blockers would decrease the left side of the heart function. If you give them too much, it'll drop the blood pressure. Older drugs, it does do that, like verapamil, but DILT's pretty safe. But remember, the problem with DILT is you got to make sure that the rate is the problem, not the response. So if you got that septic little old nursing home patient that's dehydrated and you don't give them IV fluids, you just give them some DILT in the field, you're going to drop their blood pressure and make a worse outcome. Cool thing about DILT though, if you give DILT and somebody gets bradycardic and hypotensive, what can you give them to fix DILT? Calcium. Yeah, it's a calcium channel blocker. Give them a little bit of calcium. Obviously, you don't want to do that, make them drop the pressure, but if you do mess up, you got a way to fix that. Esmolol is a newer beta blocker, been out about 10 years, I think, and we can get this as an infusion. So we started infusion with this, get the rate down, and then we can switch them to oral medicines. The cool thing about Esmolol in the ER is if I use Esmolol and I drop the blood pressure, I stop that drip, and the medicine's gone in a couple of seconds. You can do rhythm control with procainamide. Nobody does procainamide much anymore. It's really hard to give IV. It's coming back into play, but we don't see a lot of it. And then amiodarone works pretty good for rhythm control as well. If you got somebody that you can't give a beta blocker or a calcium channel blocker to, say somebody who's hypotensive, all right, bad heart disease, you can't give them this, but you got to slow the rate down because you think it's cardiac in nature.
Hey, Doc, would you talk a minute about the dangers of giving a beta blocker or a calcium channel blocker if the patient's having a stroke at the time?
Yeah, the only problem with that is you can lower the blood pressure. And obviously, if somebody's having a stroke, you want to increase cerebral perfusion pressure. You don't want to lower the blood pressure. Now, if that stroke is a hemorrhagic stroke, so there's blood in the brain and the blood pressure is 220 over 110, yeah, you got to lower that down to about 160 systolic. But if they're having an ischemic stroke, you want to keep that blood pressure up as much as you can to get perfusion. Same thing about, we used to give beta blockers in heart attacks all the time because the thought was lower the heart rate down, slow the heart rate down, and that decreases oxygen demands on the heart, and that's true. But the problem with that also is when you slow the heart rate down, the blood supply to the heart itself gets lower. So there's a risk to any drug you give. Anything we give in medicine is a risk and a benefit, right?
So I know that we've got beta blockers in the pre-hospital setting here in Alabama now.
Right.
It just makes me nervous that we can't always eliminate this drug.
Okay. Yeah. So we can give labetalol. We also have DILT we can give in the pre-hospital area now for AFib, RVR. We can give labetalol for hypertension. But the thing about hypertension is in the ER, I don't get concerned with hypertension until blood pressure is over like 220 over 120. So if somebody came in and they broke their ankle and the blood pressure is that high, I'm not going to treat the blood pressure. Okay, they probably live that way. I'll give them some pain medicines if their pain gets better and the blood pressure gets better. The only time we treat real hypertension in the ER and call it emergency is if they have signs of end organ failure. So blood pressure 220 over 120, having an acute stroke, I want to lower it just a little bit. Then I got to get a CAT scan to see if it's blood or ischemic. If it's ischemic, I want to keep the blood pressure up above 180. If it's hemorrhagic, I want the blood pressure less than 160, right? But there's no way to tell that in the field because there's no CT scanners, right? Does that make sense? Sort of, kind of? The scary AFib for me is the folks who have AFib, RVR, and they're hypotensive. So now any treatment that I give them medicine-wise, beta blocker, calcium channel blocker, is going to lower their blood pressure. So I really got to think, are they hypotensive and fast heart rate because of something else? Dehydration, volume loss, ischemia, sepsis. And if so, I got to be aggressive with my IV fluids and get the blood pressure up that way and hope that the heart rate corrects itself. All right. But you have some people who have bad congestive heart failure. They have a heart function of less than 20%. And because of that, the heart gets big and they get AFib underlying. And now they have AFib RVR rate of 135, 150-ish, blood pressure of 80. But they don't look septic, don't have other problems. Now what I do? Now I'm pretty concerned. If I give them a beta blocker, I'm gonna lower that blood pressure, okay? Which may also lower the heart rate and increase the blood pressure, or may just lower the heart rate and lower the blood pressure. So these guys are pretty scary to manage. The point of this is, if you have someone that you think is an AFib RVR, and you don't think they have some other cause, so it's just heart failure, bad heart disease, it's not sepsis or something, when you treat this fast heart rate, be prepared to support them with inotropes, dopamine, norepinephrine, something like that. Dobutamine is probably better, probably a lot better than dopamine. And it goes back to that output is heart rate times stroke volume. So bad heart failure stroke volume is already decreased. The heart gets sicker and sicker over years, so this heart rate gradually creeps up to keep cardiac output. And now they show up in the back of your ambulance with a heart rate of 140, decreased stroke volume, low cardiac output because blood pressure is low. You give them DILT, they drop the blood pressure, now they look like dirt. You'd give them calcium. You think about hanging some dobutamine if you're critical care, or maybe some levo. There's risk to hanging dopamine or an epi because you may get them tachycardic again. But if they have no cardiac output, you kind of hosed. These guys make me very uncomfortable. They're hard to manage. So you got to be safe with that. In the hospital, esmolol is a good drug to use because, again, I can stop it and then it's gone. Occasionally, you got to cardiovert these folks and get them out of AFib for a little while until the blood pressure gets better. But these folks are super scary to manage. So AFib, RVR, and low blood pressure is a scary, sick as dirt patient. The way you would manage this in the field initially is obviously you're going to get hands-on assessment, figure out they have AFib, RVR, they're hypotensive, you're going to get your leads on them, you can put the defib pads on them, you're going to start IV access, and you're going to look for secondary causes, something that makes them tachycardic. Most of these folks, I start fluids on them, give them 20 cc per kilo fluid bolus or a liter, and now people are thinking, but they have heart failure, they may not can take that. That's true, they may not. I may put them in pulmonary edema. But my hope is that they're volume down enough and I get a little bit of volume on them that it lowers their heart rate and the blood pressure goes up and they do better. If not, we set them up, they may have to get intubated and then cardioverted or some other medicine. But these people are sick as all get out. I'd also recommend rapid transport. When you think about long-term care of folks with AFib, we usually manage these folks sometimes on antidysrhythmics, oral medicines, beta blockers, calcium channel blockers. We used to use digoxin a lot. Digoxin works a different way, but can help slow the heart rate down. The other thing we think about is, do we put them on blood thinners? All right. So this is one of the scoring tools we use in the hospital to determine do they need blood thinners. So if I got a guy that shows up with new AFib, really no symptoms, I start thinking, does he need to be put on Plavix, on Coumadin or Xarelto or something? We use this risk factor here. So does he have a history of heart failure, hypertension? Is he mature? Diabetes risk factor or history of stroke? If he's got two of these factors, then his risk of having a stroke in the next year is greater than 2%. So we say, yeah, we probably put him on blood thinners until we can figure out a way to get him out of that AFib. All right. If he only has 1 point, then just daily aspirin is reasonable. All right, but there are risks to using blood thinners. This is another mnemonic or kind of a scoring tool we use is HAS-bleed. This is a little bit too fancy for me. The way I look at this, if I have a 75-year-old person with a history of heart failure, diabetes, hypertension, and had a previous stroke, but is also missing one leg from an amputation, he'd be a high risk. 20% chance of having a stroke in the next year, but he's also pretty high risk for falling and smacking his head. And falling and smacking your head on a blood thinner can lead to a big brain bleed, and people die from that as well. So it's a risk to benefit thing again. So it's a big discussion with the family. How do we manage that? Do you need blood thinners? If the guy tells me that he falls 2 or 3 times a week, there's no way in heck I'm gonna give him blood thinners. We hope they don't have a stroke, or if they have a stroke, they come in quickly, and then we give them TPA to break that clot up. So, all the medicine is risk to benefit in the way we manage that. Questions? Yes, sir.
The next case. So we've got a question that's come in. So in the AFib RVR, it's not listed in our protocol for narrow complex attack. So we just call for orders since we don't have RTM.
Yeah, I think that diltiazem is category B.
Yeah, it's not a required drug.
It is not a required drug, right? Yeah. So I think if you have AFib RVR and you have the patient and you're not carrying DILT on your truck now, the way you manage that is you make sure they're not volume overloaded, make sure they're not super heart failure patient. You look for a reason for that fast rate, and if they're septic, dehydrated, you give them small fluid boluses to see if they get better. And then you move toward the hospital. If you carry diltiazem and you think, or cardizem, and you think that the rate is the cause of the problem and they need DILT, I would still start a small fluid bolus, you call med control, give them the story, be confident, and then you give your diltiazem that way. The problem with DILT is it's got to be refrigerated, and I think it has a 2-week shelf life. I could be wrong. You have to look that up with the pharmacy book. And that's the big thing with DILT, is that it's got to be refrigerated. And not many places have refrigeration units, unless you're critical care. All right, this is a 67-year-old, no significant past medical history. And the answer to that question is no known significant. At 67, you're going to have health problems if you're in the South, no matter what you say, right? History of complaints of shortness of breath and tachycardia. Blood pressure is fine. Respirations are reasonable. SATs are reasonable. D-stick is 98, and this is our EKG. So too fast, too slow, or okay-ish. I would say that the rate is going to be 300, 150, so 130 to 140-ish maybe. All right, so a little bit fast. It's not too fast. All right. Narrow complex. I go back, I look injury patterns. Reasonable, reasonable. I got some depression here. Not a STEMI, but it's depression. 2-3 and AVF. Same thing, some inverted T waves or ST depression. V1 through V4 looks good, and AVR is reasonable. So a little bit fast, hand on the pulse, it feels regular, all right? But you also start looking at this and you see some different notches here, right? So it looks kind of weird. So what is this? Rate of 140-ish, regular, flutter. Yeah, that's A flutter. So A flutter is classically a rate of 140 to 150. You can usually see extra P waves or divots through here. Textbooks talk about a sawtooth pattern. Kind of looks that way. But the key thing is a regular rhythm, and it's consistent. It doesn't go 120, 130, 140, 116. It stays 142, 150, 144, right in that range. It's a 2 to 1, and that's A flutter.
Usually, what's the?
How do you manage it?
Well, yeah, because I mean, typically they're pretty stable. Right?
Yeah, exactly. So it's sort of like, so A flutter is, I call it like pre-AFib. It's somebody who's got heart disease, got some reason to push them toward AFib, they're just not there yet. Yes, sir. Yeah, 2 or 3 consistent, exactly, right, yeah. Or it's just beating twice at once. Some reason it's jacked up. Nothing you can really do for that. So 140, 150, you recognize it, you have A flutter. So now I know that you have probably some kind of heart disease, all right? You may be at risk for a PE or blood clot or stroke, higher risk for your radar to think about those things, but management's the same. Think about the cause. A flutter is the sinus tach of folks with atrial problems. So yeah, so management is not going to be the same. It's not going to be concerning, right? Here's another one, same thing. Rate 143 is pretty consistent. Hand on the pulse is regular, not irregular. That's A flutter. If they were symptomatic, we treat it the same way we do AFib. Maybe calcium channel blockers, maybe beta blockers. Try not to do synchronized cardioversion for these folks because it doesn't help long term for the most part. They need ablation. The other problem is that people can have AFib or A flutter and not be in a fast rate all the time and not even know it. So if I got somebody that's 67, 70 years old and they have AFib and they said, I've never had AFib before, I don't believe them. I think they just don't know that they've never had it before. This is A flutter as well, but this person is on a beta blocker at home normally. And you can see that you got these flutter waves, but the ventricular rate is fine. So from an EMS or ER perspective, there's nothing I'm gonna do to treat this. My mind says, yep, they got heart disease. Yep, they're at risk for strokes. Yep, there's some issues there, but there's nothing I'm gonna do to treat this. If this person, this EKG is on somebody that has now had left-sided weakness for an hour and a half and slurred speech, what's going on? What kind of stroke do they have? Ischemic or hemorrhagic, you think? Ischemic, because these guys are high risk for throwing blood clots because of the A flutter. And you don't know till you get a CAT scan, duh. But this is the person that's like, holy crap, they're an hour into the stroke. There's a chance we can reverse the stroke with TPA. So give them the stroke system, move toward the hospital, give them a fluid bolus, do the screening tool for screening for lytics, and get them to the right hospital. Perfect. So A flutter is just kind of a re-entry sometimes through here or different areas that are firing, one of the two. A flutter. This is a young lady with palpitations, blood pressure's fine, sats are fine, D-stick is good. Been doing some Red Bull. I'm more of a monster guy, but to each his own. Too fast, too slow, or okay. Too fast, right? So machine says 170. I'm gonna say 300, 150. Yeah, so it's pretty fast. My hands on the pulse, looking for regularity or irregularity. As I'm looking at the QRS, I would say it's a narrow complex QRS. Machine says 94. It looks like a box and a little bit more. So narrow complex tachycardia. What could this be? It could be a couple things. It could be AFib with RVR, except we felt the pulse and it's pretty regular. Or it could be the more common one that everybody likes to treat. What is this? SVT, right? Yeah, narrow complex, SVT, not SVI, SVT. Cool. So how do you manage this patient? What do you want to do for them? So obviously we've done our assessment. Anything that going on that could exacerbate this, maybe the Red Bull or something. You also think tachycardia and dyspnea. I always think about PE, so I'd ask a few questions. Risk factors for PE that are pretty concerning will be a female on birth control pills, any kind of hormone therapy, and smoking. Big red flag for PE. It causes SVT as well. And then some folks just get it out of the blue as well. All right. Is she volume down? I would recommend IV access. We've got our 12 lead, and then I'm thinking about American Heart does a great job with this. I'm gonna do vagal maneuvers, right? So have her bear down. You can go to YouTube. There's a lot of newer techniques that you can do. You can make them raise their feet up as they blow on the thumb and throw them back in the stretcher. Way too complicated for me. I give them a syringe, tell them to try to blow the plunger out. If that doesn't work, blow on their thumb. I don't usually ask people to bear down like they're having a bowel movement, because sometimes they do have a bowel movement, and that's not cool, right? But vagal maneuvers, and if vagal maneuvers don't work, the next thing you can try is what? Oh, yeah, that's mean, but that would vagal you. Ice water, yeah. The textbooks talk about for kids, ice water to the face. I think if somebody put an ice pack to my kid's face, I might punch the doc. But yeah, you can do that. The thing that I've seen in kids work best is a rectal thermometer. The ER tech comes over to get a temperature on this kid and puts a red thermometer in their butt, and that'll break SVT every time. But don't do that to adults. That will get you in trouble. If you don't mind, yes. So, all right, so vagals don't work. What can we do for this person? What's the drug we can give? Adenosine, right, so adenosine. So the protocols talk about you can do 6 to 12 milligrams. It's Cat B in our state. Hopefully that would change at some point. I usually just go 12 milligrams, give it IV push pretty quick, and you got about a 98, 97% chance of converting that SVT. But SVT is basically where you get a loop circuit here. There's some kind of accessory pathway, all right? So conduction starts out normally, and then all of a sudden something triggers it, whether it be stress, dehydration, fever, Red Bull, symptomatics, and you get this loop circuit, right? Just around and around. When you give adenosine blocks conduction through here and kind of resets everything and makes it work well. So adenosine's quick, it's easy, it's relatively safe, no big risk for that, as long as you have a narrow complex tachycardia. If they had AFib and they were firing from everywhere, and they had AFib, RVR, and you gave them adenosine, what you can see is you can see a break slow rhythm, there'd be fib, and then the QRS comes back. And I can't draw that with the Duerring. But with narrow complex tachycardias, adenosine's pretty safe. You can always synchronize cardiovert these people as well. We don't want to give it for Y complex tachycardias, because if you have a Y complex tachycardia, you know you have an accessory pathway. And if you actually have AFib and you block this, there's a chance this AFib goes to VFib. It's all theoretical, but I'm not a big fan of giving adenosine to Y complex tachyes. Let's see, did I have that EKG? There you go. So the other thing, when you think about SVT, elevation in lead AVR in a narrow complex tachycardia makes you think SVT as well. It's just another reassuring fact. Heart rate 170, 180, it's regular, narrow complex. I'm up in AVR. I'm pretty consistent that this is probably SVT or AVNRT. When you Google SVT video, you get a bunch of this dude. I'm not sure who that is. He must be some singer that is a SVT name or something. Anybody know him? Oh, really? You know him? Wow. Oh, okay. It's like, I don't know who this guy is, but you Google SBT and you get a bunch of this dude. But SBT, right? Cool. When you push your adenosine, make sure they're still on the monitor. In the ER, we keep them on our 12-lead machine and run a rhythm strip, but it gives you some information. You can push that adenosine. If they go into AFib and then get back, you know, okay, it wasn't SVT, it was AFib. There have been many a time that I've pushed adenosine on narrow complex tachycardias, and it's like, oh, it's actually a flutter, not SVT. No harm, no foul. So adenosine is a relatively safe drug. I'm not going to go over why complexes today. I'm going to take these slides off. I'm going to show a few other EKGs. That's for Chief Ward, that's for you. Yeah. So quick review from a couple of weeks ago. Too fast, too slow are okay. I said the machine says the rate's fine. I'm doing 300, 150, 100, so we're good. So around 100. I'm looking at injury patterns. I'm looking at leads 1, AVL, and lateral. This stuff here is a little bit concerning, but the T wave is okay. 2, 3, and AVF, funky, but the T wave looks fine. V1 through V4, I got some depression here and here, pretty concerning. I go to AVR, and again, the QRS complex is jacked up, but the ST segment actually looks pretty well. So I start looking for intervals. If your interval's fine, my QRS is wide. Oh, so my QRS is wide. All right, so now I think about bundle branch blocks. And I'm thinking, is it a left or a right? Anybody remember how we determine that? We look at lead V1. All right, a left bundle branch block, the QRS points down. In a right one, it points up. So this is a right bundle branch block. And with a complete right bundle branch block, you see this stuff right here, this ST depression. So now, my initial thought with this patient was, crap, they're probably having a posterior MI. But now I've gone through my system, I've looked at everything, I recognize a wide QRS is a bundle. This is reassuring that this is a right bundle branch block. Left, the QRS complex points down. Yep. And again, so we can talk about these every time, but if you don't look at these on your own, look at a lot of them, you're not going to recognize normal, abnormal, recognize left or right bundles. So this is an EKG guy with chest pain. Too fast, too slow, or okay? I'd say the rate's okay. I'm looking at injury patterns, 1, AVL, and lateral, reasonable. 2, 3, and AVF. This stuff is not a STEMI, but it's concerning, right, for ischemia. V1 through V4 looks pretty reasonable, all right? Now, you can call these hyperacute T waves. You can say, are they hyperkalemic? Is this an early STEMI before they get elevated? Don't know, but they do look kind of funny. But then I go over here and look at lead AVR, and I'm elevated in lead AVR. If I go look at V1, I'm actually elevated 1 in V1 as well. So remember when we talked about lead AVR, elevation in AVR, depression anywhere else is concerning. I'm up in AVR, I'm down inferiorly. I got a person with acute coronary symptoms, whether it be shortness of breath, nausea, or chest pain. This is a STEMI equivalent. But what's the machine say? Don't say anything about a STEMI, right? So this was a great catch by RPS recently. This is a STEMI equivalent, guys. So this is concerning EKG in the right patient. Now, if dude says my knee hurts and I feel great, I'm going to be super concerned, right? Because it doesn't fit the clinical picture. Dude having symptoms, this EKG, this is the one you call TCC. Hey, I got a patient with an indeterminate EKG, but I think it's a STEMI. Hook me up with the hospital. They call the hospital. If the doc approves, it goes into the STEMI system. Okay? Excellent. When they get to the hospital, this is the EKG. And you can tell now that this is even more pronounced, as is that. All right? This is still here. So yes, they are still having a STEMI, right? It did not change, did not get better. Dude went to the cath lab. With AVR, remember we talk about proximal LAD, it's real high up, can be very bad. So this is the pre-cath, there's no flow. They put a balloon up, put a stent, and look at that. Flow. Excellent catch by that RPS crew. Excellent catch. This is another AFib. Too fast, too slow are okay. I say the rate's okay. Injury patterns look reasonable, nothing super scary. Intervals, I don't see P waves. QRS is normal. My QT, really kind of blunted T, but it looks fine as well. So this is AFib, non-RVR. If you have this patient, there's nothing to treat related to this EKG. I would talk to this guy in the hospital, history of AFib or not, yes or no. If no, this is new AFib, and I feel he's good to go home. We'll talk about does he need anticoagulants or not anticoagulants, like we talked about earlier. Too fast, too slow are okay. Too fast. So if it's too fast, narrow Y complex QRS. Narrow, hands on the pulse. Is it regular or irregular? Feels pretty regular, we'll say. And then I go back up and look at the AVR. I'm up in AVR in a narrow complex tachy. This is probably SVT, and it was. So this guy, we tried vagals, did not do much for him. And then this is a rhythm strip here, 3 leads before we give some medicines. I think that's hilarious. And this is him with adenosine. So SVT here, rate is 300, 150, so his rate's 180, 190-ish. A little bit of adenosine, and you can see, kind of breaks it up. We got P waves, then it catches back up, and we go back. He was tachy into the 120s, 130s for a few minutes, but he just got adenosine that makes people feel really bad. They get nauseous, feel like they're gonna pass out. All the nurses, everybody in the ER freaks out because we had asystole for a couple of seconds, but not bad. And we start looking for reasons why the guy went into SVT. We check electrolytes, do some cardiac test, give him some fluids, and hopefully he gets to go home. This one's kind of hard to see, but this is another SVT that was picked up by LifePack. You can tell up in AVR, narrow complex, that's SVT. Questions, comments, statements within reason.
Earlier, one EMS made the comment that they carry diltiazem in a powdered version that can be to eliminate the shelf life issue. I didn't know that.
I didn't know that was possible either, so that's fantastic to know. So for those that didn't hear that, you can get DILT in a powder form to reconstitute. So cool, exciting. Remember, if you're going to use DILT for AFib RVR, make sure that you look for other reasons for them to be tachycardic. You don't want to give somebody who is volume down septic, the heart rate of 160, DILT before you give them fluids, because you're going to drop their blood pressure and make them do bad. So pretty cool. DILT's good.
Clarification on the previous question. The question was really about getting orders for any odorone or AFib RVR.
Oh yes, you can call for that. Yes. Yeah. I'm not sure if it's in our protocols or not, but amio is treated, is indicated for any tachydysrhythmia. So if you had that patient who had known heart failure, you ask them, do you know how bad your heart failure is? And they say, well, I have a defibrillator. At that point, the heart function is less than 25%, so sick heart, and their AFib RVR and their blood pressure is low. Yeah, I call Met Control. Hey doc, I got a 60-year-old male with a history of heart failure, has an AICD placed already. He's tachycardic, hypotensive. Can I give some amio? Any reasonable ER physician will say, yeah, give him some amio. It's not going to lower the blood pressure. It may fix the AFib RVR and make their heart rate better. If the heart rate slows down and they look worse, stop the amio infusion. Okay, you're probably just going to do a bolus.
Amio 150 milligrams over
10 minutes. Yeah, very slow. Yes, sir. Sure is. Cool. Good thought process. Other questions or comments within reason?
There was a text that came into me wanting to make a clarification. You were not advocating the use for adenosine in VFib, correct?
No. If I said that, that was a mistake.
Yeah, so they can't hear me, so.
Okay, yeah, so the question was adenosine and VFib. No, do not use adenosine and VFib. If I said that, my caffeine titer was way too low. Adenosine is used for narrow complex tachycardias. American Heart is beginning to say that you can use adenosine for regular tachycardias that are Y complex if you think it's SVT with aberrancy. I'm not a big fan of that. So me, I'm a simple dude. Narrow complex, regular tachycardia gets adenosine. Anything else does not. They get electricity or something else. But do not use adenosine for VFib. That is wrong. Very wrong. The other thing about SVT is a lot of people get SVT and sinus tach confused in younger people. And by younger, I don't mean kids. I mean 20-year-olds, 30-year-olds, healthy folks. So if you got a guy, let's say you got a dude that's nursing home patient, paraplegic from a GSW, and now he's got a urinary tract infection and he's septic. And you show up, his blood pressure is 90/40, heart rate is 140, and then 160, and then 170, and then 140, and it's regular. So that regularity makes you think SVT, but the fact that the rate changes from 140 to 160 to 130 tells you it's not SVT. SVT is a loop circuit, remember? So that loop circuit means that rate's going to be reasonably about the same. Now, I might say 160, 164, 162, that's reasonable, but it shouldn't jump 10 or 20 points. That's probably sinus tach. So that dude gets IV fluids because you think he's septic, and hopefully he gets better. And if he doesn't, and he stays at a rate of 160 that looks like a narrow complex, then you think about adenosine at that point. Now I'm just talking way too fast. All right. Thank you for smiling. We're going to take a 5-minute break, and Dr. Duerring is here. Oh, the password today is, hang on, youth. Yes, youth is the password.
All lowercase? All lowercase.
Yes. And don't forget, if you show up in person, we have t-shirts. All right. Thank you for smiling. All right. Back in about 4 or 5 minutes, guys.
All right, guys. So we're going to talk today. We're just going to run through some pediatric cases. This is meant to be super interactive, so we'll see how it goes with most people being online and like 5 people in the room, but we'll get there. It's COVID. Everybody's online. LSU and Alabama can't play, but we're still having an AEMS challenge. I'm just saying.
This is the second year that LSU has not lost to Alabama. You know that.
No comment. They got COVID on purpose. You can't lose if you all got COVID and can't play. I'm just saying. All right, guys. So none of these cases are incredibly complex. This is not meant to be like a head scratcher or like complex case report kind of weirdness, okay? These are all actually fairly simple and straightforward cases for the most part. But they are all cases that I have done QAs on in the state in the last couple years, okay? So these are kind of not complex, but they're all examples of things where meds were given wrong, meds were given in the incorrect dose, things were maybe not done that could have been done to make things go better on the call. And so none of these are meant to be like super head scratchers. If you're sitting there going, well, this is really easy, this is obviously X, it probably really is X. And the point of it is to discuss the management a little, the assessment of the patient, and then the management of it a little more, so that we can all take good care of these sort of common and really sort of like everyday PEDS calls to make sure that we're doing the right stuff, okay? Because things change over time. All right, so again, we're going to talk about calls, we're going to discuss transport and common pitfalls. So every single one of these is difficulty breathing as your dispatch, because we all know that difficulty breathing covers everything from an arrest to a seizure to a dead person to God knows what. Difficulty breathing can be 3 billion different calls. And so that's sort of the idea here, is all of these are going to be the same similar sort of setup, and then we have to see where we end up, okay? So this one's an 8-month-old female with difficulty breathing. You arrive on scene with significant respiratory distress. She's working hard, you know, she's red and rashy, and mom tells you they tried to give her scrambled eggs and gave her eggs for the first time today, all right? She's never had eggs before. There's her vitals. Heart rate's 170, pressure's a little low, breathing about 50 times a minute. Sat in 84%, got some delay cap refill. Remember, cap refill in adults, we sort of scoff at and don't pay much attention to. Kids, cap refill is something we really love. It's really, really sensitive marker for how well kids are circulating, because kids really, really do rely on their increased peripheral vascular resistance and their ability to shunt blood as one of their few mechanisms to cope for shock. And so while capillary refill in adults, we sort of go, it's a checkbox on the PCR, okay, check. It really is something that really useful to look for in kids. The kid's a little fussy and difficult to console. You hear wheezing when you listen, and she's covered in a red rash that looks like that. All right, so what do we think this is? Yeah, allergic reaction, anaphylaxis. Again, this isn't made to be too overly complicated. So we think about when we assess kids, we always form our primary survey or our primary assessment. We always sort of think about the assessment triangle. And really what we want to know is sick or not sick. That's what we care about. We don't want to miss the sick kid, okay? And so really what we care about in EMS more than anything else is who gets an easy ride to the hospital and who's the sick kid that I need to like up the pucker factor a little bit and do some things for, right? So assessment triangle has its three parts: appearance / sort of airway, work of breathing, and circulation to the skin. So looking at this kid, thinking about those vitals, thinking of that exam, do we think this kid is sick or not sick? Sick, right? So we know we're working hard to breathe and we got some wheezing. We know our circulation is down, right? Because we got delay cap refill, we got tachycardia, we got a blood pressure that's sort of, we don't love, right? And then thinking about general appearance, kid is fussy and difficult to console and covered in a nasty looking rash, okay? So if you've got all three legs of the triangle down, we know you're a sick kid. You're in shock. You're sort of heading for cardiopulmonary failure if we don't intervene and sort of walk you back from that cliff, right? So we're going to call this kid a sick kid. There we go. So talking about anaphylaxis. Anaphylaxis is an allergic reaction. When we talk about allergic reactions, there's actually 4 types of allergic reaction depending on the way that your body creates the reaction. When we talk about anaphylaxis, we're talking about type 1 hypersensitivity reactions, okay? That one over on the far left. And those are the ones we think of as being like, people talk about IgE and mast cells and histamine, okay? This is sort of the classic allergic reaction, if you will. You have antibodies that bind the allergen, they bind to these mast cells, which then release histamine, and histamine is what mediates those allergic reactions and creates all those nasty effects that we don't love to see, okay? So food allergies are pretty common. They affect around 10% of people. It's difficult to obtain the exact prevalence because the symptoms and severity can really vary from one person to the next. There's people who know that every time they eat tomatoes, they get a little itchy, right? All the way up to the person who has full-blown anaphylaxis to like a single peanut, right? And so because of that variability, it's really hard to really classify the true prevalence of food allergies. We know that they're getting more and more common, especially over the last 2 to 3 decades. And this has been termed the so-called second wave of allergies. So the first wave, everybody got environmental allergies, right? Like hay fever, pollen, and we saw everybody with allergies, like environmental allergies and asthma, but we didn't see a lot of food allergies, right? So you think 70s, 80s, 90s, a lot of us when we were growing up, well, not many of us in the 90s, well, maybe a couple of you in the 90s. Yeah, Ferguson, of course. The fountain of youth back there. Grandpa was in bed by 8 p.m., was born in the 90s. Okay, so we had that kind of first wave where everybody had a bunch of bad environmental allergies. You saw a lot of asthma, things like that growing in prevalence in sort of the 70s and 80s. Now we're getting what we're calling the second wave, where we're seeing this increased wave of people who now have like food allergies, okay? And it seems to disproportionately affect people in industrialized nations. So these are much more common in sort of the Western developed world, and that probably owes to a lot of differences in exposure, right? We're not exposed to as much weird stuff as younger. Our immune system sort of learns to respond differently to things. They are more common in kids than adults. The highest rate, oddly enough, are actually in Australia, followed by the US. Using CDC data, we do show an increase of 3.4% in the late 90s to 5.1% in kind of the 2009 to 2014. So again, these are increasing. There are a few foods that really make up the majority of the common allergies: nuts, fish, shellfish, egg, milk, wheat, and soy. With peanuts, nuts, fish, and shellfish and egg being really sort of the most common ones. Some food allergies have a high rate of resolution. Milk especially, over 50% of people by age 5 to 10 will grow out of a milk allergy, and egg about 50% by age 2 to 9. So some kids do grow out of these, but there are others that are much less likely to grow out of. So peanut and shellfish really, really unlikely to grow out of, especially shellfish. It's almost always persistent throughout life. There we go. All right. So let's talk about anaphylaxis specifically. So we know this kid has not just an allergic reaction, but this is truly anaphylaxis, right? Girl's covered in rash, wheezing, difficulty breathing. So anaphylaxis, we know, is a potentially life-threatening manifestation of those type 1 or immediate hypersensitivity reactions. It varies in its severity. So it goes all the way from sort of some mild urticaria and vomiting to shock and death. Because anaphylaxis is really technically defined as an allergic reaction that involves 2 body systems, right? It's not just the stereotype. So if I say anaphylaxis, everybody pictures the kid in the picture, right? Covered in hives, like can't breathe, wheezing, shocky, and every day 100% that's anaphylaxis. But anaphylaxis really is 2 body system involvement. So the kid who has some hives and vomits, they have cutaneous and GI, okay? And so then we consider that kid anaphylaxis, even though they're not sort of that stereotype of the kid who's wheezing, can't breathe, throat swelling, that kind of stuff, okay? And so because of that, it has a wide range of variation. Again, all the way from that kid with some itching and vomiting up to the more stereotypical kid that we tend to think of. It can result from any route of exposure, so it doesn't have to necessarily be something that's ingested. We have some kids that are so horribly sensitive to peanuts, they pass by the little peanut grinder where they make the peanut butter at Publix, and if they inhale that dust, things start to go downhill quickly, okay? Some kids who have bad latex allergies, they touch like a balloon, they'll start to get manifest anaphylaxis. So it doesn't just have to be an ingestion. It can be from any route of exposure. And it really can manifest as either mixed upper or lower or both, sort of mixed airway involvement. It's under-recognized and under-treated, partly due to failure to appreciate that it can present, again, in sort of different ways without obvious signs of shock or throat closing. And so it's difficult to estimate the exact prevalence. We think it's somewhere around 0.05 to 2% of the general population suffer from an anaphylactic reaction. And that number is probably, that data is a little old now at this point. And we know with increasing allergies, probably honestly up a little bit from that at this point. And it is steadily increasing. The time between exposure and symptoms can vary from minutes to hours. And so it is not necessarily immediate onset. The kid who swallows, a piece of shrimp and just instantly breaks out in hives. The mean latency period is about 1 to 30 minutes. So most do present within an hour, but they can be somewhat delayed sometimes. Skin manifestations are normally the first to come out. So normally people start talking about they start to itch a lot first. And that's sort of their first sign that something's going wrong. And airway involvement can be subtle, right? It can be anything from the kid with a scratchy throat all the way up to the kid who has obvious stridor, wheezing, and looks sick as stink, okay? And about 6% of kids can have what we call a biphasic reaction. So this is why we tell any family if they give their EpiPen or if the kid needs their AviQ, whatever brand they're using of their Epi now, we tell them that they all need to come to the emergency department to be evaluated and to be watched. Because these kids get sick as stink, okay? So these are kids who get better after that dose of Epi and initially do well, but then have a recurrent reaction, okay? And these kids really, really try hard to die, okay? These are some of the sickest kids I've ever seen in my entire career are kids who have biphasic reactions, okay? Because their reaction generally is much more difficult to treat. I had a girl she was a teenager who loved pistachio ice cream but was allergic to nuts, ate some pistachio ice cream on her birthday every year and gave herself her EpiPen. And that was a good plan that worked until it didn't. And I will never forget that girl because I remember seeing the cot roll by, and one end of the desk, she looked great and was breathing. By the other end of the desk, she was covered in hives and struggling. We gave that girl so much Epi. I mean, I dumped tons of Epi into her. We had to load her with some lidocaine because she actually went into VTAC transiently from all the Epi. We could not ventilate her. We tubed her. We dropped both her lungs trying to ventilate her, did splash and dash chest tubes on both sides. She lived, did fine. But again, just sort of illustrates the point. These kids are sick, okay? So even if you guys say get there and the kid looks great after their Epi and they're like, no, I think I'm fine. The answer is no, you really need to go to the ER because we watch all these kids for at least 4 hours in the ER in order to make sure they're not having a biphasic reaction. So how do we treat anaphylaxis? Well, we all know this, right? Oxygen epi. Remember, we want 1 to 1,000 IM epi. Okay, it is the preferred medication and the preferred route because of its absorbance and its pharmacokinetics and all those good things. Okay, we do not want IV epi as our first med for anaphylaxis. I know we always have the temptation to give IV meds first because that's what we do a lot of and we're used to, but we really do want IM epi here. Okay, again, these are calls that have been reviewed, and this was one that was reviewed because we got IV epi first and we went into SVT transiently, which is always helpful when you have an allergic reaction and SVT. And so again, we want to really focus on our IM epi, okay? It's 0.01 milligrams per kilogram, the dosing you're used to, and we're going to give it intramuscularly. We do want to put an IV in these kids because frequently they're pretty shocky as well. We want to give them IV fluids to treat their shock. Benadryl, we can give them IV if we've got an IV, or we can give it IM as well. Benadryl is 1 milligram per kilogram up to 50 milligrams. And then remember, a lot of these kids who have food allergies have a lot of asthma too. We talk about the atopic triad of asthma and food allergies and eczema and skin allergies. And so a lot of these things, tend to run together. And so if they are wheezing, we want to give them some albuterol. We want to treat that as well. If they are having a refractory reaction or they start to get, kind of pre-code, then we can give them IV epi, okay? That is an option for refractory reactions or people who are getting pretty sick and we think are about to arrest and we just want to fend off some badness. IV epi is an option, but it is sort of our second go-to. It is not our first thing we want to think about. We really want that IM 1 to 1,000. All right, case number 2. Yeah. Yeah, so we always talk about 0.01 mg per kg, but really 30, unless you're a little baby, then under 30 is fine, or under 30, 0.15. The little babies, like this kid who's a 6-month-old or 8-month-old who got egg, the 0.15 is a high dose, but we do that a lot because they don't make like EpiPens in smaller than 0.15. And so we will give those kids 0.15 and we just warn mom, like, when you give it, wait for what happens next. Because they will like tack up to 220 and like be angry. And so to make it easy, you can think of it that way. And normally I would say anybody over a year, you can definitely 0.15 if they're less than 30. Once they get less than a year, those kids tend to be around, 10, 11 less weight kilos. And you probably need to try and start thinking more about actually calculating your dosage out. We don't anymore. So when we looked at anaphylaxis in kids and looked at whether or not that was useful, it didn't really seem to have any difference or change in like their outcomes or their symptoms. And so we've sort of stopped doing it now. Now, some of these kids who are super sick that we're just throwing everything, including the kitchen sink at, we still occasionally do it because we're just trying anything to keep them alive at one point, but we don't routinely use it anymore. We don't routinely give steroids anymore as well. The exception being the kids who have like asthma and are wheezing pretty bad. We really give it to them more to treat the asthmatic part of their reaction, the wheezing and the other issues. We don't routinely give like IV Solumedrol anymore to these kids either. Because again, when you looked at just kids who are having straight allergic reaction, you took out the asthma part, kids didn't tend to have any change in their outcome, change in how fast they got better, anything that seemed to be related to the steroid usage. So we stopped routinely using the steroids as well now. All right, so case number 2, we talked about all these are gonna be difficulty breathing. So this one's a 6-month-old male with difficulty breathing, arrive on scene to find the patient in respiratory distress. Mom says they've had 4 days of cough, congestion, runny nose. They saw their PCP, got diagnosed with a virus, who put them on breathing treatments. and sent them home. Kid's been doing breathing treatments at home, but doesn't seem to be getting any better. In fact, just seems to be getting worse. And then tonight, kind of woke up with some different, they noticed they were working really hard to breathe. There's your vitals. So heart rate of 160, blood pressure 86/64, breathing 64 times a minute, sat at 89%, has a decent cap refill, alert responsive. You look at the kid and they're just like pouring thick snot out of their nose. They sound like a washing machine when they're breathing with these really coarse, just junky sounding lungs when you listen to them. Has some scattered wheezing, and they're retracting and working pretty hard to breathe. So thinking about our assessment triangle, trying to figure out, we want to know, is this kid sick or not sick? Is this kid sick, not sick, kind of on the borderline? Yeah, so this kid's pretty sick. Definitely has at least one leg of the triangle down, right? They're working pretty hard to breathe. Their circulation seems pretty good, right? They're a little tacky, but their cap refill looks good. Pressure's okay. And their general appearance, the kid does look a little sick, right? Like they don't look healthy. They're not in a good mood. So we got 2 of the 3 down. So the kid's maybe not, an impending shock, but this is definitely with 2 down, a kid that's sick that we want to take seriously, okay? So what do we think is wrong with this kid? We've got a few days of cough, congestion, runny nose, some wheezing, getting worse. It has a virus. This is a pretty common setup for croup would be one thought. If you had stridor, I would say 100% you're right. So remember, we talk about 2 sounds when we talk about lung sounds and breathing, or really airway sounds. Croup is sort of an inspiratory squeak that's in the upper airway. Wheezing is an expiratory sound squeak that lives in sort of the lower airways. So we associate croup more with stridor. RSV, yeah, so bronchiolitis, perfect. So this is a kid who has bronchiolitis. This is a really common story, and it's usually, so typically RSV is the most common virus we think of with bronchiolitis, which has a really well-known time course. Kids get sicker until about day 5, and then they start to turn the corner, okay? And so this is a really common story of, we've been sick for 3 or 4 days, the doctor said we had a virus, but we're getting worse. The breathing treatment thing is a really common part of that story too, because as it turns out, we've done breathing treatments for these kids for years. When we really studied it, very, very few of these kids actually respond to albuterol. And in fact, the new American Academy of Pediatrics statement on treatment of bronchiolitis is to not give them albuterol because they are so unlikely to be responsive to it. Because the virus just creates inflammation in the lungs that isn't the same as like asthma, which is like reversible bronchospasm. It's more of like a viral pneumonitis that creates that inflammation and creates that kind of wheezing, okay? So again, this is really common in kids. It's the most common cause of hospitalization in infants during the first 12 months of life. There's about 100,000 bronchiolitis admissions occur annually in the US, which totals $1.73 billion healthcare dollars every year. That is an incredible amount of money for little bronchiolitic babies. The viral infection, it's a viral infection in the lower respiratory tract. Again, frequently caused by RSV, but there's a lot of other viruses out there. When I was training, we had the test for RSV, and that was about the only thing we could test for. So we just said RSV bronchiolitis and non-RSV bronchiolitis. If you clearly had bronchiolitis clinically, but you had a negative RSV test, we just termed you non-RSV bronchiolitis. Now we have fancy viral respiratory polymerase chain reaction tests that we can send that test for like 15, 20 different viruses from this kid's nasal swabs. And so now we know that the most common thing that causes, number 2 most common cause of bronchiolitis is coronavirus. Non-COVID-19 coronavirus is the second most common cause of bronchiolitis, which is a really fun conversation to have with parents right now when you tell them their kid has coronavirus bronchiolitis, but not that coronavirus. The next most common cause are human metapneumovirus and rhinovirus. So rhinovirus is what we get when we get the common cold most of the time, but causes in these little babies more lung inflammation and more bronchiolitis type picture. So now we no longer call them non-RSV. We actually give them a name because we can actually test for it now. But the idea is this is RSV. It can be caused by other things though. So RSV has the typical 5-day course like we talked about. The other viruses tend to not have the same course. So other viruses tend to last a little kind of longer. With human metapneumovirus and rhinovirus, coronavirus, you tend to get more of a 7 to 8, kind of 9-day course. So it tends to last closer to a week. okay, before these kids start to get better. And it really affects kids 6 to 18 months old. Again, these kids can get some mild fever, cough, congestion. The congestion and the nasal secretions, those are really the hallmark of RSV or bronchiolitis. These kids are just full of junkiness and snot. And then they can get some wheezing because of the lung inflammation. Kids who are less than 12, have a history of prematurity, have underlying heart or lung disease or immunodeficiency are more prone to having severe disease and for requiring hospitalization. And the treatment is pretty straightforward with supportive care. Airway support is needed, suction, 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 okay? So we talked about some of these were things where things were okay, but we could have done some things that maybe went better. And this is one where suctioning can make a big difference. So these kids really just need their nose sucked out. So if you don't have a bulb suction and you don't want to break into your OB kit to get one, if you don't have like a bulb suction in your peds bag, the other thing you can do is take like a 10-French suction catheter, like we use to suction out ET tubes, cut it off till it's about that long, shove it down the kid's nose, and then suction on the way out, and it'll clear out a lot of that snot and secretions. Remember, babies, especially kids under 1, which are primarily the group we talk about with bronchiolitis, are very obligate nose breathers. They do not like to breathe through their mouth. And so when they get that airway just clogged with snot, they tend to have a hard time. So a lot of their problem is a B problem, but a lot of their B problem is an A problem in this group, okay? So if you can suction that snot out and clear that airway, a lot of everything else gets better. I've had kids that came in sucking paint off the walls that were wheezing. We're like, oh, this is not going to go well. And then one of our RTs gets in there and very, very aggressively suctions them. And suddenly this kid is like a whole new baby, just sitting there and ready to take a bottle, okay? So suctioning is a big, big deal in these kids, and it's something that can make a big, big difference between a very miserable, scary ride to the ER and a very happy, calm ride to the ER. Oxygen to maintain their saturations. A lot of times these kids can be dehydrated. We talk about kids not having the same sort of fluid reserves as adults. And remember, the most common shock that occurs in kids is hypovolemic shock, not just from blood loss, but also from dehydration and sort of medical reasons, okay? So some of these kids can be a little shocky and be a little sick purely because they're dehydrated. It's really hard to take a bottle if you can't breathe and breathe through your nose. And so a lot of times these kids will have some decreased intake for 2-3 days. They're also breathing fast and have fevers and have their metabolism is ramped up. And so they have increased losses as well. And so these kids can be pretty dehydrated. So sometimes they will need some fluid resuscitation. Again, albuterol is not routinely recommended. The one group where it does tend to seem to be helpful still maybe are kids who do have a history of prior wheezing. So kids who maybe have some underlying, we don't really call them asthma at this age yet, we call them reactive airway disease. But if they have a history of prior wheezing and needing breathing treatments, then sometimes it can help. But again, we don't routinely recommend it anymore, and because most kids are going to be unresponsive to it. This thing doesn't like me today. There we go. So suctioning the kid's nose. This is a nose Frida. I find these things personally very disgusting, but a lot of parents swear by them. You stick it in the kid's nose and you literally suck their snot out of them. There's a little spongy filter that's built in right here that supposedly nothing gets to you. I don't know how much I buy this. I'm telling you, parents who buy these things swear by them though. Absolutely swear by them. The residents in my program who have kids, because I mean, who like use these things, absolutely believe that they are like the best thing ever. I think they're gross, but whatever. This is more what we typically use with is a bulb suction. The other alternative again is to take a suction catheter, kind of feed it down that nasal passage a little bit and suction on the way out. If you have like a saline flush or a little saline bullet, if you drop some saline in before you suction out, can help loosen that stuff out and kind of get it all out. And again, this can make a big, big difference in these kids. This is what it looks like when my RTs do it, because they have the little neo suckers that go down in there, and we're holding the kid down who looks like they're trying to be murdered, and they get in there and they get stuff out that I swear comes out of their like stomach half the time, but they really get in there and can get all kinds of junk out.
Hey, Doc,
yeah.
On the case where you got a couple of questions. I think in the back to the first case, the anaphylaxis case. So what about racemic epi for anaphylaxis as question one. And question two is, after the first round of medications, would it be appropriate for one additional FE1 1000 IM before the IV dose?
Yes, absolutely. You can repeat an IM dose. The IV dose is for really, you've done a couple, maybe IM doses, and or the kid who's just looking like they're ready to arrest, where slamming them with some IV epi is only going to help at that point. You can definitely repeat an IM dose. That's fine and frequently very effective. And then the other one about racemic epi, you can try giving racemic epi. Racemic epi tends to work more in the upper airway. So for people who have a lot of stridor, you can get upper airway involvement in stridor with anaphylaxis. More common is wheezing and lower airway involvement, which is why we talk about albuterol. You've also just shot them up with parenteral epi. And so that theoretically should help any of that upper airway swelling as well, just from that. But if you have some stridor, it's absolutely worth trying. But generally, we tend to see a lot more wheezing and sort of lower airway involvement, which is where albuterol tends to work best. Bueno. All right, case 3. Again, difficulty breathing. So 1-year-old female with difficulty breathing. You get there, she has some irregular breathing with intermittent snoring. She's unresponsive with stiff extremities. Mom says she's been sick for several days when she was playing and then suddenly became unresponsive and stiff like you find her, and that she feels really, really warm. So what's wrong with this kid? I heard it. She's having a seizure, right? So when we talk about seizures in kids, there's a lot of things that cause seizures. But seizures are generally not the issue that creates your problem, okay? The issue is kids are really prone to airway obstruction and or having disordered breathing when they seize. And what creates issues with kids is hypoxia, okay? So when we talk about seizures, a lot of times we hear this story of they're brought in for difficulty breathing, and their difficulty breathing is they have disordered breathing or they're intermittently obstructing their airway because they're seizing, okay? So seizures create sort of an A-B problem in kids, and that hypoxia is what gives you sort of badness with kids and seizures. They tolerate seizures actually very, very well, as long as they can have an airway and ventilate, okay? So this kid specifically, heart rate's 180, pressure's 90/50, respiration 10 and irregular, sat in 86% with a cat pre-fill, warm to the touch, unresponsive, extremities are stiff, and eyes are deviated to the right, okay? So this kid is pretty obviously seizing, right? And what kind of seizure do we think this is? Febrile seizure, yeah. So kid's warm, she's been sick for a few days, spiked a fever, had a febrile seizure. Now, looking at those vitals in this kid, do we think this kid is sick or not sick? Sick, right? Perfect. So let's talk about seizures for a minute. These are all the things that cause seizures in kids, okay? Lots of stuff. Fever is a common cause. The next most common cause is we don't know. A lot of kids, about 5 to 10% of kids will have a seizure at some point in their life while they're a kid and then never have another seizure again, okay? Kids have immature brains that are still developing and growing. And so it is not uncommon for a kid to have a one-time, what we call unprovoked, meaning there wasn't a cause for it, like fever, ingestion, head injury, that kind of thing. A one-time sort of unprovoked seizure at some time in their life, okay? In fact, it is very common. And so the last one that isn't on there is that we don't know, but you had a seizure, so you'll be all right though. But fever is a very, very common cause. It is one of the most common causes of seizures in kids. And in fact, febrile seizure is the most common neurologic disorder in infants and young children. The peak incidence is between 12 and 18 months, and we normally just say 1 to 2 years, just to make it easy. Occur in about 2 to 4% of children less than age 5. So 2 to 4% of the population of kids under 5 have a febrile seizure. These are incredibly common. They do, for some reason, tend to be more common in males. And we sort of break them down into 2 types, simple and complex. Simple is really defined as anything less than 15 minutes, not recurring in a 24-hour period, and having a generalized kind of tonic-clonic seizure, what people think of as the stereotype of seizure. So it has no focality to it, okay? Complex is basically anything that doesn't meet the criteria for simple, okay? And the good news is that outcomes of these are really good. It is not related to the height of their temperature, okay? These kids do not seize because their fever was 105 and their brain boiled, or their brain started to break down, or whatever random, really fun things that I hear on a fairly daily basis. So it turns out actually we know a fair chunk of febrile seizures are genetically mediated. And when you look at one of the most common genetically mediated febrile seizure illnesses, it's actually related to a leaky sodium channel in their neurons, that when they get a fever, that channel starts to leak more and open up, and that's what creates the febrile seizure. So the point is, these are really related to the chemical changes that occur in the brain when the body resets its temperature set point as you spike a fever. So it is not that your temperature got so high your brain shut down or anything like that. They actually, people always worry about, well, if they had a febrile seizure, they must have meningitis or some serious infection, right? And actually, in the modern world. Now, in the 1970s, when we saw a lot of pneumococcal meningitis and Haemophilus influenza B meningitis and a lot of other things that we tend to not see now, that was a different story. But in the modern world, these don't correlate to your risk for meningitis or serious infection. In fact, meningitis is found in less than 1% of infants with a cipral febrile seizure, assuming they have no other risk factors or signs or symptoms of like serious illness. And so then you say, well, what about the complex febrile seizures? Because if you're complex, that's obviously worse, and maybe we need to be a little more worried about those kids. Well, it turns out you're still pretty uncommon. You start to approach about 1% in kids who even have complex febrile seizures. So the idea here is that these kids are not super sick. They don't have meningitis. Most of these kids, are just fine. And we really don't do a ton for them in the ER. It's a very minimal workup. And in fact, the most we do is we sort of let them sleep it off, wait for them to wake up, make sure they get to baseline, make sure they have a thorough exam that looks for the source of their fever. And that's really about it. Most of these kids go home and do just fine. So 2/3 of these kids will never have another seizure. Of the third who do, the most common of the third who have a recurrent febrile seizure, only 1/3 of them ever go on to have any sort of recurrent or epilepsy or underlying seizure disorder. Most just have recurrent febrile seizures and tend to grow out of them by around age 6. So how are we going to treat this kid, right? So this kid is actively seizing. So we talked about most of the issues we see that come as a problem related to seizures with kids are really related to hypoxia from their disordered breathing regulation or from their airway kind of occluding. And so we want to support their airway. And this is where nasopharyngeal airways work great. I didn't use a ton of nasal airways when I took care of adults because they just, if I need an airway, we're going to intubate them. But nasopharyngeal airways work great. Again, a lot of these kids are sort of 1 to 2 years of age. And we talked about that group really likes to breathe through their nose. And so if you can put an NPA in that gets that kind of behind that tongue and opens up the primary way they like to breathe, these kids' airways go great, okay? Plus, once they stop seizing, as they're waking up and getting ticked off, it's really easy just to pull out. Okay, you don't have to worry about them waking up and starting to gag and vomiting and aspirating and other stuff. Okay, so NPAs are great to support their airway. Oxygen to maintain their saturations. If they're like with this kid who's only breathing about 10 times a minute and very irregularly, they have disordered control of their breathing related to their seizure. We obviously can assist their ventilations and bag them. And then what do we do next? Well, the true answer is honestly be patient. So of febrile seizures, a large majority of them, greater than 90%, will terminate within 10 to 15 minutes, okay? After that, the risk of it stopping on its own starts to drastically go down, okay? So sometimes the answer is less is more, and sometimes being patient and bagging them and watching them and giving them a minute is maybe the right answer. Now, chances are, by the time you guys have gotten the 911 call, gotten there, this kid's already been seizing for at least 10 to 15 minutes. And so your chance of this stopping on its own starts to get pretty low. And then we start thinking about meds, right? And what do we want to give this kid? And how do we want to give it? Because we really have several meds that have several ways we can give them, right? So in Alabama, we have Versed or midazolam, Ativan or lorazepam, and Valium or diazepam, okay? And we can give those a bunch of different ways. So Valium can be given IV, IM, rectally. Ativan can be given IV or IM. And Versed can be given IV, IM, or intranasally, okay? Of the three drugs, the two we tend to like the most are Ativan and Versed, okay? Valium is just a really dirty drug and it creates a lot of oversedation, okay? So when we talk about Ativan and Versed and we look at them, Ativan is a great drug as long as you can give it IV. Ativan is not well absorbed IM, and there's no other route that it can be given, okay? So it's great as long as you can get a line. How much do we feel great and confident in our ability to get lines into seizing, 12-month-olds? I don't feel great about it, all right? And I do it a lot more than most people, all right? So this is the reason that we really love Versed in kids, because Versed is incredibly well absorbed IM, and you can give it intranasally, okay? So intranasal Versed is 0.2 milligrams per kilogram up to 10 milligrams as your initial dose, okay? It works incredibly well. So Valium used to be the gold standard of seizure meds, okay, before we had other meds. And so a lot of the studies that look at seizure meds and new ways of giving them still compare to Valium because it was sort of the gold standard for a long time. So compared to IV Valium, intranasal Versed has the exact same rate of seizure control, okay? So you don't lose anything as far as the chance of you stopping that seizure, okay? Then you look at time to control of seizure. So if you compare IV Valium to intranasal Versed, intranasal from time of administration, intranasal Versed takes about a minute longer, a little less, about 45 seconds. Okay, so it does take a little longer to work. But if you compare intranasal Versed to IV Valium from time of arrival to seizure control, which one do you think is a lot better? The Versed, right? Because you don't have to put a line in the kid, which saves you about 5 extra minutes, give or take, okay? So intranasal Versed is incredibly effective. It works just as well as sort of the gold standard drug. And in fact, when I can't get a line and people in the ER right away, that's what I give them, okay? It's very successful and it works great. And I encourage people to carry Versed for seizures because, again, it's really effective in adults as well. And it gives you multiple routes of administration that you can choose from, okay? And the math is pretty easy. It's either 0.1 per kilo IV or 0.2 per kilo intranasally, right? Even I can do that math. I move the decimal point in their weight one spot, and then either that's my dose, or I multiply it by 2, and that's my dose. So even I can do that math on the fly. And then what else should we check in kids? It is never a wrong answer to check a blood sugar in a kid, okay, especially a seizing kid. Even if you're really confident that this is just a febrile seizure, it is never wrong to check a blood sugar because we see a lot of these little kids who are sick for a few days. Yes, they're febrile, but the other issue, and maybe it's a febrile seizure, but their other issue is if they felt like crap, they haven't been eating, they haven't been drinking, and kids don't have a lot of sugar reserves. So we find a lot of these that we thought were febrile seizures initially, and then we go, oh, their blood sugar is like 30. Okay. So it's never wrong to check a blood sugar in a kid, okay? Now, if the seizure is over and the kid's waking up and looks like $1 million and it's bouncing off the walls, you don't have to hold them down to check it. Okay, but if they're still actively seizing or they look sick, then there's never a wrong answer of checking a blood sugar in a kid who's sick for any reason, but especially a seizure. All right. Yeah.
If a febrile seizure is the body's way of resetting after, do you see that without intervention, does it tend to work? Does the fever go down?
Yeah, I mean, we always give them Tylenol, but eventually your fever will go down, yeah. So this is really just a reaction.
I mean, do you see it drop?
Not always, because a lot of times, again, the seizure, so it's not really the fever that's the reaction, it's the seizure is the reaction to the body resetting the temperature set point as a result of a fever. So the fever is still there, but they still wake up, and we give them Tylenol so that they're happier, because then we can look at them and go, look, they're bouncing off the wall, Mom. They look great. And so their fever will go down like a lot of times on its own, but it's not an automatic that because the seizure stopped, their fever will go down.
Because by the time we get there, they're
Yeah, a lot of times when you guys see these kids, they're already done. They're sleepy and post-ictal. You know, mom is like wigging out and like running around screaming like something's, you know.
trying to convince you that that's a seizure.
Yeah, yeah. And so a lot of times these are maybe a blood sugar check, making sure their SATs look okay and that they're breathing okay, and a pretty easy, lazy ride to the hospital, right? And that's really common, and that's fine too, because usually after about an hour or two, these kids, their post-ictal state passes, they start to wake up, their fever comes down, and I'm telling you, if you guys, after you drop them off, came back to the ER in 45 minutes, you wouldn't even recognize the kid, because they're bouncing off the walls with a sippy cup watching Mickey Mouse Clubhouse and singing along to every song in there, okay? So a lot of times these are not necessarily, you know, worrying about pulling up Versed and stuff like that. A lot of times these are just sort of easy rides to the hospital because the kid's post-ictal and a little sleepy, and sort of the muss and fuss part are over. The biggest part for you and for me, 90% of the time, is walking the parents back off the cliff, right? No, he's okay. He's going to be fine. He's breathing. It's going to be all right. These are really common. And most of our job is normally just bringing calm to a place that is not calm. Yeah. All right. Got time for one more real quick. So dispatch an 8-month-old, again, difficulty breathing, arrive on scene defined with rapid, shallow respirations.
1 a.m. tomorrow.
Siri set an alarm for 1 a.m. Arrive on scene to find an infant with rapid, shallow respirations, has been sick for several days with fever and cough, decreased oral intake since yesterday, only 1 wet diaper since yesterday. This evening seems sleepy with some difficulty breathing. There's your vitals. Kid's febrile. Mom took his temp before you got there, 102.7. Heart rate's 180. Pressure's 50/30. Breathing 62 times a minute. Satin 88%. Has mottled extremities. Capillary refills 6 seconds. Those extremities are cold to the touch. So for those of you who haven't seen modeling, this is what modeling looks like. It's this sort of lacy blue pattern that kids can get over their extremities as they start to shunt blood and increase their peripheral vascular resistance. And then capillary refill, we all know, kind of squeeze the foot, the toe, whatever. 6 seconds is not good. So what do we think is wrong with this kid who's febrile, tachycardic, cold extremities, delay cap refill, been sick for a few days? He's septic, right? So sepsis has become a huge, huge deal in the last few years with things like the Surviving Sepsis campaign and stuff like that. So assessment triangle, is this kid sick or not sick? Yeah, this kid's sick. We got all 3 legs down. We're not living in a good place. Leading cause of, so sepsis is the leading cause of morbidity and mortality in healthcare utilization for children worldwide. In the US, it's actually number 2. Number 1 is trauma. But behind trauma, number 1 in the US and number 1 worldwide. 1.2 million cases of childhood sepsis per year, and it accounts for more than 4% of hospitalized patients less than 18 years, and about 8% of patients admitted to PICUs in the developed world at any given time. So a big chunk of folks. Mortality for children with sepsis ranges as high as 50% depending on the illness and severity, 4 to 50%. So these kids are sick, and these kids tend to not necessarily do well. The majority of children who die of sepsis is from refractory shock and multi-organ dysfunction, which occurs within 48 to 72 hours of onset, okay? And again, one of the leading causes of death in children in the US and worldwide. Early intervention and resuscitation, though, with goal-directed therapy can change outcomes. And this is the whole point of the Surviving Sepsis campaign, is early recognition and early goal-directed therapy in order to try and improve outcomes from sepsis. So how we treat sepsis in kids? We treat sepsis as septic shock, right? So access, first and foremost, okay? We got to get access. But if that kid has those mottled extremities like in this picture, probably not the easiest access, right? They're already shunting blood pretty hard, but they are in shock, right? And what's a category A procedure for a kid in shock is an IO. This is a kid that it is completely acceptable to drill. I don't care how awake they are. That kid's probably going to be pretty sleepy, but that is a kid who is clearly in florid shock. And if you drill that kid, nobody will fault you. If they do fault you, you give them my email address and tell them to contact me about it, and we will have a discussion. Okay? That is a kid that every day that you see, if you can't reliably get IV access in 1 to 2 attempts, you should drill that kid. Because starting fluids in that kid and starting goal-directed resuscitative therapy can be the difference in that kid surviving or not. Okay, because the earlier that we do things, the better our outcomes are. Okay, so 20 mLs per kilo is what we call a bolus for a kid. There's questions now about normal saline versus lactated ringers. Anybody who's been in medicine for 5 minutes knows that we have had this discussion 3,000 times. Currently, we're on a pro-LR streak. I promise you in a year and a half, we'll be back to a normal saline streak. Okay, this has gone back and forth 300 times. Right now, we say LR. If you give the normal saline, it is still perfectly acceptable though. All right, whatever you have, just give it. 20 mLs per kilo, all right? We generally give about 3 boluses before we start thinking about pressors. Depending on how sick that kid is though, that number is a little malleable, okay? And remember, if you're giving it through an IO, you're gonna have to be really squeezing that bag. We want that fluid in as fast as we can. We don't want drip, 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 drip. We're talking squeeze or take your blood pressure cuff, inflate it around the bag, and basically create a pressure bag to squeeze that fluid in, whether it's the IV or the IO, okay? So we want to get that fluid in and we want to get it in quick. After 40 or 60 per kilo, if that kid is still sick and shocky, we need to start thinking about some other stuff, okay? Remember, we do want to give them some oxygen, right? This kid is obviously hypoxic, but even if they're not hypoxic, kids love oxygen and it'll help them compensate for a shock state a little bit. All right, doesn't have to be a 15-liter non-rebreather. If the kid's sat and crappy and working to breathe, maybe they need a 15 liters, but if they look okay, a couple liters by a cannula is fine. Fix anything reversible, so their temp, and I don't mean their fever, I don't care if they get Tylenol, but keep them warm. If they're getting cold, because we have them laid out on the cot and it's a cold day and we're doing stuff, that shock is gonna get worse. Babies do not like to be cold, okay? So keep them warm, check their blood sugar. These kids don't have a lot of sugar reserve. They haven't been eating or drinking well for a couple days, and now they're in a shock state. Their blood sugar may be a problem. They may have burned through those sugar stores already. And then if we're getting, again, we've done these things, we've put in our 40 to 60 per kilo of fluid, and this kid is looking sick, our pressure still stinks, our heart rate is still crazy high, this kid is still shocky, we got to start thinking about vasopressors. And then we start to talk about which one and how. Currently in Alabama, we got 2 in the regular kind of ground protocols, not the critical care protocols. So we're talking about dopamine or epi, okay? The Surviving Sepsis campaign has basically abandoned dopamine, all right? Dopamine is great because it has a long shelf life and it comes in pre-mixed bags. That's why it continues to be used in ERs and ambulances across the country, despite that. Because it's easy to get and it lasts a long time. It has like a 1-year shelf life in a pre-mixed bag, right? So for something we're not using a ton, it makes it easy. It's quick to get, all right? If you're gonna be using dopamine, start at least 5, if not 10 mics per kilo per minute as your drip. Again, the problem with dopamine though, is it only goes as a drip. How great or how many of us carry pumps in our ambulance, right? How many of us are great at finding the 60 drop, micro drop set and then counting and doing the math to figure out 10 mics per kilo per minute in a 14 kilo little kid? I'm not without a calculator and a lot of unit conversions, okay? And so our other option is epi in the form of push dose epi. This is now in the protocols as an alternative to dopamine, and it's really easy to make and use. You take a 10 ml flush, you squirt out an ml. You draw up an ml of 1 to 10,000 IV epi. Shake it up, okay? So you have 10 mLs. You've changed that concentration from 1 to 10,000 to a 1 to 100,000. okay? And you push 0.1 ml per kilo of weight up to 1 ml. It is super easy, it is super simple, and it is super effective, okay? So it is really easy to give and really easy to do, and to be honest, it's something we're much more used to. We are much more used to pushing 0.4 mLs of a drug than we are at hanging a drip. Okay, so there's a lot more muscle memory and comfort with that route of administration. And so I really recommend, if you have this kind of kid, giving them some push dose epi if you're in that situation.
So the big potential mistake there is draw
Yeah.
1 to 10,000 is not always some pre-filled syringe. And so have to do 1,000 syringe to make it 1 to 10,000.
Yeah. Or if you have vials, some places are actually carrying the vials of 1 to 10,000 now. But yeah, so if you're only carrying 1 to 1,000 because you don't have the premixed syringes or for whatever reason, then you're going to have to do essentially a double dilution to get it to where you need it to be. If you've got the pre-filled, either vials or pre-filled syringes of 1 to 10,000, the IV, then you're good to go. You just squirt out an ml and draw up an ml, and it makes it easy. And this is all in the protocols now, by the way. You can download them offline. All right. And I ran over, as always. We don't have time for the last one. All right, guys. Any questions?
We have a question online. So the question online is, if we have a 20 kilogram patient, this is back to epi for anaphylaxis. We already
Okay.
hung up on that today. So we have a 20 kilogram patient with a dose of 0.2 milliliters of 1 to 1,000. So how far can we go with dosing? Because the second dose would put us over the max. So I think the confusion here.
So the max of 0.3 is for each individual dose. You can give more than that. Now, this is very specific to kids, okay? The adults do not like multiple doses of epi because adults have hearts that are unhealthy. And that's why I think if you're going to give a second dose, if I remember right, the protocol says you have to call med control. But that is built in mainly for the adults because their hearts don't love a ton of epi because most 60, 70-year-olds don't tolerate big slugs of epi very well. My kids, who all have great healthy hearts and can tack away at 220 for 2-3 days if they have to, they will tolerate it very well. So that max dose is a max of each individual dose that you're giving. So if you give 0.2, you give 0.2. If you need a second dose, you give another 0.2.
Okay. So the other question that was texted was max dose and protocol for midazolam for kids is 5 milligrams.
For intranasal?
It says max dose.
Hmm.
It says IN preferred 0.2 milligrams per kilogram, IN via atomizer, max 5 milligrams.
Are we looking at the most current version? Because I'm pretty sure that was a typo in the first set of the 9th and we changed it.
Just download it from the website right now.
All right, well, maybe it didn't get changed. Well, it should be 10. We'll change that. Go with 5 until I get it changed. I was like 99% sure because 5 was put in there initially because of some logistical issues, but it should really be 10 for intranasal.
Okay.
So we may need to, we'll look at that. I thought we had changed that, but maybe I'm wrong.
That's all the questions I had that came in.
Okay.
Thank you so much. Great lecture as always. We always get a lot of requests for pediatrics. If you don't mind, Scott, just tell them to get their attendance form and the password is youth one more time.
Oh, yeah.
We'll sign it off.
Don't forget to get your attendance form. The password for today is youth, like the youthful West Ward.